wait for everyone to take seats. All right, good evening, everyone. My name is Adam Cameraman. I'm an anaesthetist at Charlie's, and like all of you, by virtue of your presence here, I'm a regional anaesthesia enthusiast, having completed my fellowship at Charlie's a few years ago. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today. I'd also like to pay my respects to ancestors and elders past and present. Thank you all for coming to the biannual WA Regional Anaesthesia Journal Club meeting. We have speakers tonight who have travelled all the way from Sydney, from the southwest of WA in Busselton. I think that even some attendees have come from Netherlands and the Dalkeith area, so thank you guys for all making the distance here. It's great to see so many people here tonight, and this meeting's attendance list continues to grow each year. Based on the RSVPs, there's a good mix of public and private consultants, trainees, and also some acute pain service nursing staff here, reinforcing our aim of making this as inclusive as possible. Thank you to Dr. Chris Mitchell for helping to organise tonight. Mitch's audit of his adductor canal catheters at Hollywood will be presented later on by Dr. Michael Connolly. Without our sponsors, tonight wouldn't have been able to have happened. So thank you to Lydia and Ratika from Avant, to Michelle Buchanan from ICU Medical, to Kate and Kiali from Duke Medical, Michael O'Hara from Sonosite, Palapal from Medtronic, who unfortunately couldn't be here tonight, and to Tom, Linda, Lishka and Zoe from Biberon. Zoe will be giving a presentation shortly. We very much appreciate all of your support of our meetings and look forward to seeing you at future events. Some quick housekeeping. If you notice upon arrival, there's a QR code just outside over there. If you can log your attendance, you'll get a certificate which will be sent to you at the end of the night for 2 points for your PDL. We'll also add your emails to the WASORA website to ensure that you receive all of the latest regional anaesthesia updates in Perth and all of the meetings. Bathrooms are outside and to the right. And I hope that you've all managed to get a bite to eat. Feel free to stick around afterwards to have a bit of a mingle and something further to eat or drink. We have 4 fantastic speakers lined up tonight to educate us on the latest in topics such as intrathecal prilocaine, video logs in regional anaesthesia, and audits of adductor canal catheters versus single shot blocks. We'll aim for all speakers to follow one after the other, and we'll leave some time at the end for some questions. So if you could just please save your questions until the very end. There is normally some roaming microphones, but tonight I've been told that there aren't any roaming microphones, so I have to just talk loudly. Finally, if anyone has any suggestions on content or would like to contribute themselves to future Journal Club meetings, please let me know at the end of this evening so we can facilitate this. Our first speaker is Dr. Miles Earl. Miles has travelled all the way from Busselton, having moved there 10 years ago from Perth. He was previously the head of Department of Anaesthesia at Busselton Hospital and has extensive experience in the use of intrathecal prilocaine, for which he has kindly agreed to share his wisdom with us tonight. Please welcome Miles.
That's me. Sweet. All right. Thanks, everyone. I am Miles Earl. Some of you may remember me from training back here many years ago. I know the housekeeping's sort of been done, but my housekeeping side of things is that I've lived in the country for 10 years now, so swearing is part of the normal vernacular. So I will drop some F-bombs and stuff accidentally because it's just part of daily life. You should feel sort of very happy about the fact that I've actually wore pants, because normally I wear shorts all year round, and this was me dressing up, so it's all I had with me. The other thing I've learnt in the country is if someone talks about old mate, that could be anyone. They're not going to tell you who old mate is, and the story will continue and you'll never know who old mate was, but it doesn't matter. And the other thing I've learnt about this experience now is that I have a bad habit of volunteering for things that I think are a lot smaller than they are, because I got asked recently to do a talk similar to this with no preparation to the board of WACS, which I thought was just, they said a couple of people from the board of WACS, and it was a room of 50 people with, you know, Neil Fong and all these other people, and it was, and I did no preparation. So today will be very similar. I don't have any conflicts of interest, but I fucking love tapentadol, so I talk about that a bit. And there'll be a fair bit of shameless boasting about our achievements at Busselton. Right. So Busselton's a low acuity public hospital. We're essentially the satellite site, well, we're the satellite site to Bunbury Regional Hospital, but we're essentially the day case hospital. We have the same surgeons, but there's no flow of nursing staff and other support staff across the two sites. So it's basically surgeons across the two, anaesthetists some across the two, and then everything else is pretty independent. It has 2 operating theatres and a procedure room. A majority of our surgery is orthopaedics. We do about 1,500 eyes a year, cataracts a year, but it's largely day case stuff. And 2018, when we started joint replacements, we do about 200. We were doing about 200 per year. Now I know I'm meant to talk about prilocaine, but I'm just going to take a little bit of time moving towards that, purely because I have no idea how long my talk's going to take, and then I can speed up when we get to the point where I should be talking about prilocaine. So our first joints in Busselton were in May 2018. We set a very low bar on that day, and we had 2 total knee replacements planned for the whole day, and that went relatively well. There's no surgeons in the room, are there? Yeah. It went relatively well. And then we sort of have moved on from there to doing 200 or 300 a year. We essentially do 4 in a day. In most lists, we could definitely do more, but it's more equipment is our issue there. The length of stay on our very first patient was 2 days. The discharge criteria from that patient was the surgeon said she is to leave after 2 days. So it worked, I think. So when I was setting up this, we had to do a lot of education through the whole, the ward staff to get them used to intrathecal morphine or just surgical patients, because it was basically sort of a nursing home which had there weren't many overnight stays, and any overnight stay was sort of just it was maybe, we didn't even do gallbladders. It was probably maybe a bit of gynae surgery, that sort of stuff. There was very little overnight stays. There was no governance over who looked after them, and we had to sort of work out a medical model around that. And the reason I put this intrathecal morphine eye opener was that it made me understand and learn so much more about the journey of a patient that you don't realise when you're doing like anaesthetics in your training program, that sort of stuff. You're not following up any of the patients. And we were doing all of the medical care for these patients, 2 pain rounds a day, because we had no pain team, we had nothing else. And I would have to, I think I'll put this in a bit further on, and we had to teach the nurses what intrathecal morphine went, and it made me realise that things like intrathecal morphine actually have all these extra nursing requirements on top of them, and people patients would be given the intrathecal morphine, but then the patients got less sleep, more observations overnight, and then I was sort of starting to think about how can we make this a bit easier for them, and that's when I sort of went away from intrathecal morphine, moved myself towards huge doses of tapentadol as my pre-med instead, and just had people on whacking doses of tapentadol. And I was using hyperbaric bupivacaine at the time, so the patients were in bed for 24 hours afterwards. We just piled them full of anything we could, well, everything. This is still referring to the first patient. We gave her no regional anaesthesia. The surgeon just refuses it. And we would have to do our pain rounds. I'd have to go at 6:30 in the morning, do a pain round, then drive to the regional hospital, do my list there. Then I had to ring the pain nurse and do a handover of what I've just decided. And it was really clunky, cumbersome, and a lot of hard work by a lot of people. And then we sort of evolved the system to get rid of intrathecal morphine, moving more towards pre-meds, and then moving towards low-dose bupivacaine. And so I was... I basically just texted a surgical mate and said, what dose are your anaesthetists using for their low-dose bupivacaine? And he said, 0.8 to 1.2 mils of heavy bupivacaine. So I went, all right, we'll give that a go. So then moved towards that, got rid of IDCs, and the patients were leaving quicker, but it wasn't perfect. There were times where the patients just had this prolonged block despite the fact that we'd only given 1 mil of bupivacaine. And also one of the big problems around it was the fact that we had multiple anaesthetists who were all doing completely different things, which, that's fine in a normal surgical ward setting because all the people are expecting it. But we did all this education with the nurses to explain what intrathecal morphine was, to explain... because they'd previously been nursing no surgical patients, and so we had to teach them about all that. And then you'd have one person gives intrathecal morphine, one doesn't, another person gives a PCA. They can't put together a PCA in the middle of the night because there's not the person who knows how to do it, and it was just really quite difficult. So from that, we evolved... Luke Kane, who's the current head of department at Busselton, he started doing some research around it and deciding that he would try to work out how to get prilocaine. I put preoperative, I'll come back to that later. So once we wanted to start using prilocaine to see what we could do with it, but we had to go through the TGA approval special access scheme. And I don't know, knowing a lot of anaesthetists, I suspect most people won't have come across it because most of us don't even like picking up a pen to draw a couple of little lines. But it requires a fair bit of work to go. You've got to go on, set up your ID, and then you've then got to, for every individual patient, get approval and write why you want approval, and then you have to send that over to East, and then they'll send you back an approval the next day. And I'm pretty sure they got used to us doing it, and it was just us sending it across because it would start to come back really quickly. But there were problems with pharmacy because it wasn't, I've said prescription required to order, but the issue wasn't that you needed a prescription. It was the fact that we then had to print out the 6-page approval from the TGA, and then we had to sign it and also change for some reason, even though you put all these details in, you then have to write ampule on the 0.5% instead, the 2% instead of just saying 2%, and you had to write hyperbaric, and it was just really cumbersome. And then we got sort of used to it, but we had to do all that just so that they could order it. And then we were finally allowed to use it. We have, on our audit data, we've got 126 cases. I've said across 2 consultants. There are, to my knowledge, there's 2 of the 126 done by other consultants because I did the paperwork for them. It was just easier. We've been auditing our joints since 2019, and I'll come to that audit data in a little bit, and I'll also come to sort of a bit more details about how we use prilocaine and sort of the funny things about it. But with that audit in 2019, we have been quite an attractive place for the residents to come to, because then they can get papers and they use all our data to produce papers. And we've had a couple of, one guy recently, some people who went to Ansgar ASM would have seen Tim Yap's paper, which I'll just pop up at the end of this, on IDCs in comparing prilocaine to high dose bupivacaine and sort of low dose bupivacaine. Unfortunately, our RMO sort of supply has sort of changed a little bit, which is making things a bit more difficult from that point of view. Now, so prilocaine, it's reliably short acting. Now, I think I'll just put this whole page up and then I'll just talk about the whole thing. I've heard some people tell me that they've used it and they said, I used 2.5 mils and it was, patient had a lot of pain and recovery and all that sort of stuff. And I'm like, I fill the syringe to the top, then I squirt out a little bit of air, draw up even more, and then if I know that I need longer, which is based on the surgeon fucking around or the surgeon is going to let the registrar do a lot of the operation, then I'll add another 15 mics of clonidine into that as well. I've always been pretty full on with my efficiency in anaesthesia, and with this I've had to consciously slow down and just sit there and wait to do my spinal, because I know that if I do it before the nurses have done all their stuff, or my surgeons decide to go and have lunch, then it's not going to last to the end of the case. Which is not, as I said, it's not a deal breaker with giving analgesia in recovery and all that sort of stuff, but I just want to avoid, the whole point of doing this is I'm trying to avoid giving too many opiates. One of the things that I've noticed with prilocaine is that there are still sometimes where it's just, there's no explanation, but it just hasn't worked, but then it has worked. So even quite recently, the patient moved significantly when the surgeon started, and it had been 20 minutes from when I'd done the block, and then I went and asked, I thought, well, it hasn't worked at all. So I just went and got 500 mics of fentanyl out of the cupboard, drew it up, and then the patient stopped moving and was absolutely fine for the rest of the case. So I still can't quite work out why, and they had a block that was sort of perfect and wearing off in the appropriate amount of time. But it does seem that, and I'll take back a step, I still GA all of these patients as well. So I'm not testing any of these blocks. So, and same with Luke, he doesn't test them. He just routinely, it's just do the block, GA, and off we go. But it appears sometimes that it's got a slower onset and then still has the same drop off at the end. So you may get some movement at the start. And I still can't fully explain it, but I'm also not prepared to do these patients awake to find out. When you're using it, you're genuinely you're looking at this almost fixed window that you're dealing with, and so you really need to communicate well with your surgeon to make sure that they're actually not going to disappear, and you're just going to have to time the whole thing. And I've also done some prilocaine for non-joint surgery, and I do it for Achilles repairs and that sort of stuff, and I'm using about 2.5 mils with a sedated patient, and they're all super easy. But it doesn't seem, the block doesn't onset as quickly as heavy bupivacaine. And I don't know. I'm not 100% sure on that. Now, the other thing with the analgesia in recovery is that a couple of our anaesthetists have been really hesitant to use prilocaine because they say that they've got a slow surgeon, or it's not always that the surgeon's slow, it's that we've got a couple of surgeons that insist the tourniquet has to be up until they have had their lunch. And so we've got 80, 90-minute tourniquet times on some of these patients, and they don't want to use prilocaine because they're worried that they're going to have to give them something else. But in our opinion, and look at my sort of experience with it, is that it doesn't matter. You're just going to titrate in some fentanyl at the end, and titrating in fentanyl because the block started to wear off is not a bad thing, and it's a completely controlled environment to do so, rather than on the ward, the block's wearing off and they're having pain problems there. There's quite a few things I still can't explain with it, that like my surgeons put in their local anaesthetic pretty early and it should be working by the time they hit recovery, but these patients do appear to have more pain in recovery, but it's rare that we'd give more than 100 mics of fentanyl and then they're fine, absolutely fine. We're mobilising them pretty much as soon as they get to the ward. Our IDC rate is about 1 in 50, and we actually only ever use intermittent catheters. We don't put IDC in anyone as a first line. And we've got the hang of it now that we know it's going to last 2 hours, and we're just going to prepare for that as we go. Most of our patients get big doses. So everyone gets paracetamol, tapentadol pre-med. I use 150, sometimes 200, 250 as pre-med. And Luke is a bit more conservative on that side of things. I still haven't got around to using celecoxib as a pre-med pure, for no particular reason other than it just seems too difficult to organise, because then pharmacy got to have it in the right place, and I don't know how much money I'm saving by doing that. So now we can see some data. So you'll see on this that basically our patients used to, in 2019, 3 days was a standard stay, and now we're down to 1 day. And most, I think this one looks right. This is for people who are familiar with the Health Round Table. It's basically comparing like-for-like hospitals around Australasia. And our median length of stay for hip replacements is 1.36 days, and knees 1.95. It hasn't separated out unicompartmental knees, because I think it's about 70% of our unicompartmental knees probably leave within 24 hours. And our emergency readmission rate is lower than everywhere else. And across 90 facilities and 30,000 joint replacements, we are have the shortest length of stays of all of those places. These are our first, I think it's almost in order. This gentleman got in trouble for actually taking his crutches off the ground by the surgeon because he wasn't meant to do that. And the lady on the very right, she would have been our first day zero discharge, but she lived in the bush and we hadn't known how well she was going to go and hadn't prepared her. So she hit discharge criteria at 3 p.m. on the day of her hip replacement. But then she came back, I think only 4 weeks later, had the other one done and was out the same day. One thing that people then question with how quickly we're getting patients out is whether the patients are happy. We have an incredibly thorough post-op follow-up of our patients. So the model that we've sort of done is that our pain nurses have become a perioperative nursing service. And so they're involved with patients, organising the lists and that sort of stuff from the start, and then obviously seeing them in the normal capacity of a pain nurse. And then they call if we get a patient out on days, well, basically 0 or 1, they get a phone call within 24 hours. They get another phone call at 72 hours. Everyone gets a phone call at 1 week, 1 month. If they're still on opiates at 1 month, they get another phone call at 2 months. And the patients all, because the pain nurses share an office with us, and it's just like our pain nurses just having a chat with these people. They're just ringing them up and going, "Hey Barry, how you going? what's been going on. And it's probably for us, that's been the crucial thing that's made us, allowed us to do what we've been able to do, having that follow-up. And then the last thing I'll just point out, this was the paper that Tim Yap, one of our residents, presented at the World Congress and at the ANZCA ASM. But the key thing with it is that essentially the higher the dose of bupivacaine, the longer everything is. So it was a pretty linear sort of relationship. If you want to give, the low dose bupivacaine was 1.5 and below, and high dose is 1.6 and above. And basically, the more bupivacaine you got, the more hypotension you got, the more catheters the patient's got, and slower discharge. And so there was a significant difference dropping down to low dose bupivacaine, but that came even better when we moved to prilocaine. And the key thing for us with prilocaine was that we were more confident with our patients under the anaesthetic than with bupivacaine, because you felt, because we were sort of trying to fly so close to everything, we were worried that with our bupivacaine, you'd get the same length of block, but you're sort of just coming up and you might not have ever hit the right level, and you'd have patients moving for the whole case, and you're doing a hip and they got a block to L3 for the whole thing. And then that L3 block lasts for 6 hours. And it was just slow to mobilise and all that sort of stuff. So we definitely noticed once we moved to prilocaine, it was much more reliable, and it was just more definite, but you have to be prepared for when it's going to wear off. All right, thanks.